I am Dr. Minagogo Hart, a cardiothoracic surgeon. I'm going to be giving a short discussion on the significance of the findings from our research. We conducted a research to determine the effectiveness of the use of single chest tube or double chest tube following decortication of the lung for an indication of stage 3 empyema thoracic. This research was conducted in Ethiopia in 3 major hospitals: the Grand Abasa Specialized Hospital, which is the largest referral hospital in Ethiopia, the Middle 2 Referral Hospital, and the St. Peter's Specialized Hospital. The research spanned a period of 15 months from 2021 to 2022, and it involved 62 consecutive patients with the diagnosis of stage 3 empyema. 8 surgeons were involved in the research. Now, draining of the chest following lung resection in thoracic procedure using tube has been a common practice for thoracic surgeons around the world. However, most thoracic surgeons have shifted from the use of 2 chest tubes to the use of single chest tube. Unfortunately for us in sub-Saharan Africa and underdeveloped countries, thoracic surgeons still use 2 tubes to drain the chest. Now, we decided to study empyema thoracic because of the increased volume of patients we see in our center. And these increased numbers can be attributed to the increased resistance in anti-tuberculosis treatment and our poor road network, poor traffic route that have led to an increase in the incidence of road traffic accidents. Our primary endpoints were the amount of drain per day, the duration of drain, and the pain score in our patients. The secondary endpoints were the presence and magnitude of air leak, the need for resetting the chest tube, the length of hospital stay, and the presence of subcutaneous emphysema. In our study, the age range between 18 to 70 years of age with a median of 44 years. There were more male patients involved in our study as compared to female. We also understood or discovered that 45.2% of our patients had a history of previously being treated for tuberculosis, whereas 35.5% had a history of chest trauma where tube thoracostomy were used for the treatment. In our study, the drain output was very significant in patients with 2 drains as compared to patients with single drain. The number of days the drain spent in our patient was lesser in patients with single drain that spent for 4 days, whereas a patient with 2 drains, the drain spent for up to 8 days in them. The pain degree of pain were the same in both groups. There was no significant difference in the amount of pain our patient felt. And also in our secondary endpoints, we realized that the presence of subcutaneous emphysema, air leak, or resection of the chest tube was not influenced by the presence of the number of chest tube, rather by the magnitude of the pathology of the patient and the level of decortication and lung injury during intraoperative findings. The median length of hospital stay was significantly higher in patients with 2 tubes, as most patients spend up to 22 days in the hospital, as opposed to patients with 1 tube, where patients spend 13 days. In conclusion, we see that empyema thoracic is a commonly occurring pathology in sub-Saharan Africa, with tuberculosis and trauma being the major underlying causes of empyema thoracic. We see the use of single chest tube is associated with less drain output, shorter hospital length of stay, and shorter duration of drain, whereas the use of double tube is associated with increased drain output, longer duration of drain, and longer length of hospital stay. The use of a single chest tube, we conclude, is as effective as the use of double tube in the treatment of post-decortication empyema thoracic. Thank you. These are our references.